We'll go ahead now. Dr. Maldonado, please go ahead and ask your question.
Yeah, thank you so much. So first, a brief comment and then a question. I just wanted to reinforce what Dr. O'Leary said about the clinical terms that we use. As clinicians, when we talk about something that's rare versus we see it all the time, so it's not rare to us in certain, tertiary, quaternary care centers, but I really want to underscore that issue of definitions for the general public and understanding risk perception and assessments that you're going to be dealing with later on. So I think it's really important to understand those definitions and what we as clinicians might use versus what we talk about when we're looking at overall safety of products that are used in medical practice, in medical and public policy. So that's a comment. The question I have is, from the beginning of this case series that we started to hear about, I wondered about the association between the second dose or perhaps really a longer-term response to a first dose or something that happened, sometime before. And the reason this is important, I think, is because physiologically it would be helpful to understand what is the mechanism of this potential association would be. And if it's associated with a second dose, it's happening very quickly and it's very different. It could be very different from what we've seen with other myocarditis etiologies. And so it would be helpful for biological plausibility to understand whether the timing is related, for example, to 3 weeks and 3 days after the first Pfizer dose or 4 weeks and 3 days after the first Moderna dose. And I wonder, Dr. Shimabukuro, if the data are available on the interval between the reports and from the first dose, not the second.
So I don't have the specific data in front of me, but we did ask the VSD investigators that question, like, how do you not know, or how can you tell the difference between maybe something delayed after first dose versus something happening after second dose? And they did a review of the data, and their conclusion was that this is more likely the timing is associated with the second dose versus something delayed after the first dose. Again, I apologize, I don't have the specifics with me, but it is something that we asked the VSD investigators to look into, and they did come to that conclusion.
Thank you. We're going to cut off questions because we have additional presentations to get through. But for the next two persons, which are Dr. Chen and Dr. Shaw, please limit yourself to the questions if at all possible. Dr. Chen, please go forward.
Yes, thank you. I'll try to be brief. So I'm reviewing the symptoms, for the case definition of myocarditis and pericarditis, and simply, I wanted to know what are the current symptoms that are listed in the VSAFE that are being actively collected, and have those symptoms, say, for example, chest pain in specific, been added to VSAFE so that we can have better collection tools?
So the VSAFE reactogenicity data fields are pretty standard and have been set since the beginning, and they're fairly general. They're injection site reactions, and then they're common systemic reactions. There is the opportunity to free text in there. I don't think that VSAFE is the best surveillance system or tool to detect and assess for myocarditis. I think myocarditis being specific, being typically serious in the sense that it's a medically attended event, is better captured in VAERS and better monitored in the Vaccine Safety Data Link, where we have complete or near complete information from electronic health records.
Thank you. Dr. Shaw?
Thank you, Dr. Romero. Dr. Shimabukuro, bottom line up front, my question is whether in the reports that you've received, you've seen any evidence of geographic clustering of the cases. The reason I ask goes back to a comment made 2 questions ago, which is we have, I think, perhaps posited that there is a biological link between those, but I've wondered if there could be a behavioral link. That is to say, individuals having been vaccinated are more likely to go outside and potentially see exposure to enteroviruses, adenoviruses, things of that nature, whereas previously they would have been cloistered inside. One way to get at that might be to see if there has been any geographic clustering. Thank you.
In short, we don't have any clear or obvious evidence of geographic clustering of cases. We're observing them, or they've been reported from multiple geographic regions.
Thank you. Dr. Hahn, your hand is up. Is that a residual from the question that you asked previously?
I'm sorry, it's residual. I'll take it down.
Thank you very much. As always, Dr. Shimabukuro, thank you very much for your presentations and your answering of the questions. Thank you, Dr. Lee. We're now going to move on to presentation by Dr. Wallace, tag teamed with Dr. Oliver on COVID-19 mRNA vaccines in adolescents and young adults, benefit risk. Please go ahead.
Good afternoon. Next. COVID-19 vaccines are currently recommended for persons 12 years of age and older in the United States under FDA's emergency use authorization. Next. In this presentation, we will discuss the risks after COVID-19 mRNA vaccines in adolescents and young adults. Next. As well as the benefits of COVID-19 mRNA vaccines in adolescents and young adults. Next. To frame this benefit-risk discussion, I will start by presenting data on the public health problem, including COVID-19 infections and complications in adolescents and young adults, with a focus on epidemiology in adolescents and young adults 12 to 29 years of age, post-COVID conditions, including MISC and MISA, and myocarditis. Next, I will present our benefit-risk assessment, including benefits of mRNA vaccines and risk of myocarditis after mRNA vaccines. We will end with the workgroup interpretation and questions for ACIP. Next. Next. This figure shows the number of COVID-19 cases reported to CDC over the course of the pandemic. Since January 22, 2020, more than 33 million cases of COVID-19 have been reported to CDC. Overall, COVID-19 cases in the U.S. have been declining since January. Next. The figures on this slide shows projections of incident COVID-19 cases from the Scenario Modeling Hub. The colored lines represent different model projections, and the black line is the projection for the ensemble model. The figure on the left depicts projections assuming 83% vaccination coverage and low variant transmissibility, and the model on the right assumes 68% vaccination coverage and high variant transmissibility. Based on these projections, incident cases may increase in the setting of low vaccination coverage and high variant transmissibility. Next. These are our latest national nowcast projections of the proportions of circulating SARS-CoV-2 variants from CDC's COVID data tracker. These nowcast projections provide timely estimates while accounting for limited sequence data availability. The stacked bars show the observed historic estimates and the most recent nowcast projections for the commonly sequenced SARS-CoV-2 lineages in the U.S. by 2-week interval of specimen collection date. Lineages that have been classified as variants of concern, or VOCs, are colored in orange shades. Lineages classified as variants of interest, or VOIs, are colored in purple shades, and other lineages are in blue. VOCs are an increasing proportion of SARS-CoV-2 lineages circulating in the U.S. For the projections for the 2 weeks ending June 19th, B117 remained the most frequent lineage with a projected prevalence of 52%. P1 increased to 16%, and B16172, also known as the Delta variant, increased to 21%. Next. This figure shows cumulative COVID-19 incident rates by age and sex from April 1st to June 11th, 2021. In these recent data, we see that adolescents and young adults have the highest COVID-19 incidence rates. Next. Since the beginning of the pandemic, at least 7.7 million COVID-19 cases have been reported among persons aged 12 to 29 years. I will focus the remainder of the presentation on this group. Next. In this figure, we see the proportion of total COVID-19 cases by age group over time. As more older adults are vaccinated, adolescents and young adults make up a greater proportion of total cases. 33% of cases reported in May were in persons aged 12 to 29 years, compared with 28% last December. Next. This figure shows the weekly COVID-19 associated hospitalization rates for 12 to 29-year-olds. Despite other age groups experiencing recent decreases in hospitalization rates, COVID-19 associated hospitalization rates have remained stable in adolescents and young adults. Next. This figure shows cumulative COVID-19 mortality rates by age group and sex from April 1st to June 11th, 2021. Looking at recent months when incident cases have been lower, COVID-19 associated deaths continue to occur in adolescents and young adults. Since the beginning of the pandemic, 2,767 COVID-19 deaths have been reported among persons aged 12 to 29 years. 316 have been reported since April 1st. Next. Post-COVID conditions can also occur after COVID-19. There is no standardized definition, but is generally understood to be new or persisting symptoms from acute infection or exacerbation of a chronic condition 4 weeks or more after SARS-CoV-2 infection. Post-COVID conditions have been reported after infections ranging from asymptomatic to severe. There is currently limited data in adolescents and young adults, but recent cross-sectional studies have shown evidence of new or persisting COVID symptoms in this age group. In these studies, up to 1/2 of study participants had symptoms 1 month post-diagnosis, and the symptoms reported included fatigue, insomnia, rhinorrhea, muscle pain, headache, lack of concentration, exercise intolerance, dyspnea, and chest pain. Next. Multisystem inflammatory syndrome in children, or MISC, is a post-COVID condition which is a severe hyperinflammatory syndrome occurring 2 to 6 weeks after acute SARS-CoV-2 infection among persons less than 21 years old, resulting in a wide range of manifestations and complications. 60 to 70% of patients are admitted to intensive care, and 1 to 2% die. 4,018 MISC cases have been reported as of June 2nd, 2021. The estimated incidence of MISC cases is 1 per 3,200 SARS-CoV-2 infections. 36% of reported MISC cases occurred in persons aged 12 to 20 years, and 62% of reported cases have occurred in children who are Hispanic Latino or Black non-Hispanic. Next. In this figure, you see the reported MISC cases in the blue line and daily COVID-19 cases in the dashed line. Lagging by a couple of weeks, MISC cases track with COVID-19 incidence, and if COVID-19 cases were to increase, we would also anticipate an increase in MISC. Next. Multisystem inflammatory syndrome has also been reported in adults, though cases are less common. A single-center retrospective cohort study identified adults at risk of MISA from those hospitalized with a positive SARS-CoV-2 test result. 1.7% of hospitalized patients were diagnosed with MISA. Patients with MISA were younger and more likely to have evidence of SARS-CoV-2 infection documented by serologic testing compared to acute COVID-19 patients. Other demographic characteristics and comorbidities did not differ between MISA patients and acute COVID-19 patients. 8 of 15 MISA patients had cardiovascular involvement. In a case series of 27 MISA patients, antibody testing was required to identify SARS-CoV-2 infection in approximately 1/3 of cases. Patient ages ranged from 21 to 50 years, and 96% of patients belonged to racial or ethnic minority groups. 3 patients died. Next. Now we'll move on to the epidemiology of myocarditis and pericarditis. Myocarditis is inflammation of the heart muscle, and pericarditis is inflammation of the outer lining of the heart. Myocarditis and pericarditis generally occur more frequently in young adults, men, and persons with certain underlying medical conditions or who have had recent medical procedures. They can also occur after SARS-CoV-2 infection, but data to estimate the frequency after COVID-19 is limited. There is a spectrum of disease, but for the purpose of the benefit-risk discussion, we will refer to both myocarditis and pericarditis as myocarditis. Next. In a recent cohort study, 1,597 collegiate athletes with recent SARS-CoV-2 infections had cardiac MRI, and 37, or 2.3%, had abnormal MRI findings. However, 65% of the 37 had normal lab findings and no symptoms. Another study suggested some MRI findings may be related to remodeling from athletic training. Studies have also highlighted differences between myocarditis related and unrelated to SARS-CoV-2. In a retrospective study which identified children with acute myocarditis treated at a single center from 2018 to 2020, 27 children 18 years of age and younger were identified. 7 cases had evidence of prior SARS-CoV-2 infection or exposure, and 6 were ultimately diagnosed with MIS-C. Individuals with myocarditis or MIS-C related to SARS-CoV-2 had a better clinical course than those with myocarditis due to other causes. None were diagnosed with acute fulminant myocarditis. There was a shorter duration of inotropic drug support and ICU stay, and they did not require mechanical respiratory support. Next. As was discussed in previous presentations by Dr. Oster and Dr. Shimabukuro, there have also been cases of myocarditis after mRNA vaccines reported. These reports have been most commonly in males less than 30 years of age, symptom onset clusters in the week following vaccination, and early data of acute outcomes have been good. Many of the cases have been hospitalized, but usually for a short duration. No long-term data are available yet, but continued monitoring is ongoing. Next. In summary, COVID-19 incidence, hospitalization, and mortality rates are decreasing overall. However, variants continue to spread, and scenarios exist in which cases increase in the fall. Adolescents are a growing proportion of cases, given vaccine coverage among adults. Post-COVID-19 conditions also impact adolescents and young adults. 4,018 MIS-C cases have been reported to national surveillance. Myocarditis is a disease marked by inflammation of the heart muscle, and risk factors include younger age and male sex. Myocarditis can be related to SARS-CoV-2 infection. Myocarditis after mRNA vaccines have been noted, with highest frequency in males aged 12 to 29 years following second dose. Early outcomes have been encouraging, but no long-term data are available yet. Next. Now we will move on to the benefits and harms. Next. I'll begin by describing the benefits of the mRNA COVID-19 vaccines, including estimated COVID-19 cases and hospitalizations prevented by mRNA COVID-19 vaccines by age and gender. Then I'll present the potential harms of the mRNA vaccines, looking specifically at the estimated cases of myocarditis after mRNA COVID-19 vaccines by age and gender. Next. The Phase 3 clinical trial data for the Pfizer-BioNTech COVID-19 vaccine demonstrated efficacy against symptomatic laboratory-confirmed illness among individuals 16 years of age and older, with an overall efficacy estimate of 95%. The vaccine efficacy against COVID-19-associated hospitalization was 100%. The Pfizer-BioNTech COVID-19 vaccine also demonstrated high efficacy against symptomatic laboratory-confirmed COVID-19 in adolescents aged 12 to 17 years. Overall efficacy was 100%, and immunogenicity was non-inferior to the 16 to 25-year-old population. Next. The Phase 3 clinical trial data for the Moderna COVID-19 vaccine demonstrated efficacy against symptomatic laboratory-confirmed COVID-19 among individuals 18 years of age and older. The overall efficacy estimate was 94%. The vaccine efficacy against COVID-19 associated hospitalization was 89%. Next. Additionally, multiple real-world effectiveness studies from the United States and other countries demonstrate that a 2-dose mRNA COVID-19 vaccination series in the age groups for which the vaccine is recommended is effective against SARS-CoV-2 infection, with an estimated range of 64 to 99%, and effective against COVID-19 associated hospitalization, with an estimated range of 87 to 97%. Next. In this slide, you see the cases of myocarditis reported in the 7 days after dose 2 of an mRNA vaccine. There have been 133 million vaccine second doses administered and 636 reported myocarditis cases as of June 11th. Next. We performed an individual level benefit risk analysis to evaluate the direct benefits and risks per million mRNA COVID-19 vaccine doses, which we used to examine the sex and age difference in risks and benefits. These calculations are based on recent COVID-19 case and hospitalization incidents, mRNA vaccine efficacy, number of mRNA vaccinations to date, number of persons already vaccinated, myocarditis risk within 7 days after dose 2, and using a 120-day risk period. We will also describe the benefits of vaccination at the population level. Next. This figure shows the COVID-19 hospitalizations prevented on the left and cases of myocarditis on the right for every 1 million doses to complete the 2-dose series of mRNA vaccine given by age group. These estimates are based on age-specific hospitalization rates as of May 22nd and are calculated over a 120-day risk window. Next. When comparing COVID-19 hospitalizations prevented to risk of myocarditis, the benefits clearly outweigh the risks in the older populations, so we will focus further discussion on ages 12 to 29 years. Next. In this slide, you see the predicted cases prevented versus myocarditis cases for every million second dose vaccinations over 120 days. For females aged 12 to 17 years, we estimate that for every 1 million doses to complete the 2-dose series, 8,500 COVID-19 cases, 183 hospitalizations, 38 ICU admissions, and 1 death would be prevented. And we estimate that we might see 8 to 10 cases of myocarditis. For males aged 12 to 17 years, we estimate that per million second dose vaccinations, 5,700 COVID-19 cases, 215 hospitalizations, 71 ICU admissions, and 2 deaths would be prevented, and we might see 56 to 69 myocarditis cases. Next. In persons aged 18 to 24 years, the benefit-risk balance is more favorable. For males aged 18 to 24, for whom the risk is higher than females, we would expect to prevent 12,000 cases, 530 hospitalizations, 127 ICU admissions, and 3 deaths, and estimate that we might see 45 to 56 myocarditis cases. Next. Finally, in persons aged 24 to 29 years, the benefit-risk balance is even more favorable, and this trajectory continues with increased age. Next. There are additional considerations for direct benefits which we were unable to capture in our benefit-risk assessment, such as prevention of MISC, prevention of prolonged symptoms, and protection against variants. Next. For population-level considerations, there are no alternatives to mRNA vaccines for the foreseeable future in adolescents. Vaccination of students offers an additional layer of protection against COVID-19 and can be an important tool to return to normal. Higher levels of vaccination coverage can lead to less community transmission, which can protect against development and circulation of emerging variants. Racial and ethnic minority groups have higher rates of COVID-19 and severe disease. Potential changes in vaccine policy or anything that would impact vaccination coverage for adolescents and young adults may disproportionately impact those groups with the highest rates of poor COVID-19 outcomes. Next. The direct benefit risk assessment shows positive balance for all age and sex groups. It considers individual benefits of vaccination versus individual risks, and the benefits presented are likely an underestimate because the analysis was performed using reported rates of cases and hospitalizations, which likely represent only a fraction of the true cases that have occurred in the population. There is still uncertainty in the rates of myocarditis after mRNA vaccines. Not all cases are verified, and the crude rates were used. The balance of risks and benefits varies by age and sex, and the balance could change with increasing or decreasing incidence. There is limited data currently on risk of myocarditis in the 12 to 15-year-old population due to the timing of recommendations and limited number of second doses given. Next. For clinical considerations in the workgroup interpretation, I will hand the presentation over to Dr. Oliver.
Thank you so much, Dr. Wallace. So I'm briefly going to describe the draft clinical considerations around myocarditis and pericarditis and the workgroup interpretation. Next slide. So these are draft vaccine considerations in people with a history of myocarditis or pericarditis. The clinical considerations website will be updated with additional language for each of these recommendations, but we wanted to share a brief summary. First, for those with a history of pericarditis prior to COVID vaccination, these individuals can receive any FDA-authorized COVID vaccine. Next, for those with a history of pericarditis after the first dose of an mRNA vaccine, but prior to the second dose. Because the risk of clinically significant sequelae related to pericarditis is considered low, people who develop pericarditis after the first dose of an mRNA vaccine may proceed with administration of the second dose after resolution of pericarditis-related symptoms. And people who have a history of myocarditis unrelated to COVID vaccination and who have recovered may receive any FDA-authorized COVID-19 vaccine. And finally, for those with myocarditis after the receipt of the first dose of an mRNA COVID vaccine, but before administration of the second dose, it's unclear how a person with a history of myocarditis after the first dose of an mRNA COVID vaccine may respond to a second dose. Until additional safety data are available, experts recommend that administration of the second dose of an mRNA vaccine be deferred. Administration of the second dose of an mRNA COVID vaccine series can be considered in certain circumstances. The clinical considerations document will go into further detail for these situations, but experts recommend that patients who choose to receive the second dose of an mRNA vaccine should wait until at least the episode of myocarditis is completely resolved. In such cases, a conversation between the patient, their parent or guardian, and the clinical team, which may include a cardiologist, could assist with decisions about proceeding with vaccination, though a conversation with a healthcare provider is not required before vaccination. Again, the final language will be posted to the clinical considerations website, but this is a summary of the current proposed recommendations. Next slide. Next, for the workgroup interpretation of the benefit. Next slide. The workgroup reviewed the data presented here today and discussed the benefit-risk balance. Overall, they felt that the initial presentations are reassuring. However, continued monitoring of cases, the clinical course, and long-term outcomes of myocarditis after mRNA vaccines will be important. They also felt the need to follow the benefit-risk balance as we learn more around myocarditis, as well as updates to epidemiology, including the current epi of cases, variants, etc. However, they felt that currently, the benefits still clearly outweigh the risks for COVID vaccination in adolescents and young adults. Next slide. So as a reminder, this is our current vaccine policy for COVID vaccines, that COVID-19 vaccines are recommended for persons 12 years of age and older in the United States under FDA's emergency use authorization. Next slide. So these are the questions we would like to pose to ACIP. What does ACIP think about the benefit-risk balance of COVID-19 vaccines in adolescents and young adults in the setting of the reports of myocarditis? And what additional information or analyses could inform these discussions as we continue to closely monitor this situation? Next slide. While ACIP thinks about those questions, I want to make sure that we acknowledge the small but mighty team that has worked on this. Although shown on the left and including Dr. Wallace are on our ACIP COVID team, and the groups on the right have been fantastic collaborators helping pull together data for us. Now, previous slide. And so Dr. Romero, I'll turn it back over to you for ACIP to discuss these questions. Thanks.
Thank you both, Dr. Wallace and Dr. Oliver, for your presentations. I see hands going up already, so let's go ahead with Dr. Lee.
Thanks so much. I actually have a clarifying question, and then I'll let others respond to these particular questions. But this is the first time I think I've sat back and really noticed that there has been a gender difference in terms of outcomes associated with COVID in young individuals. So if you go to slide 14, I was struck by the differences in COVID-19 associated deaths, where there seems to be a male predominance here. And then was also noticing in the modeling slides, which you don't have to go to, 32 to 34, that the severity of disease appears to be somewhat worse in males. So I'm wondering if anyone can comment on this gender difference, and also whether or not we have any understanding of what was the cause of death in these COVID-infected cases.
So this is Dr. Oliver. I'm happy to take kind of an initial stab at that, and then we can see if others have additional thoughts. Part of this, we know, so if you look actually at the incidence, it's slightly higher in females than in males. I think there's two factors in this population specifically. We know that there has been routine screening going on for obstetric-related care. As young women of childbearing age who are pregnant are presenting to care. So we may be picking up kind of asymptomatic cases in a pregnant population. So I think that could be contributing to the differences, the gender differences that we're noting. In addition, there could just be care-seeking behaviors where females may be more likely to be tested and seek care with maybe more milder symptoms, whereas there could be differences when males initially present for care. Dr. Wallace, or I see Dr. Erin Hall is on the line, who's with our EPI task force. I'll see if either have anything else that they would like to comment on that.
Thanks, Sarah. This is Erin Hall. Nothing further really to add to the comments you've already provided. Thank you, though.
Very good. Let's move on to Ms. McNally's comments, questions.
Thank you. I continue to be reassured by the safety monitoring systems, and I'm very grateful for the transparent communication. For me, it's clear that based on current information, the benefits of vaccine clearly outweigh the risk related to this incidence of myocarditis. But I do have a question. Given the vast interpretation that the data available to date suggests a likely association with mRNA vaccination and adolescents and young adults, I wanted to know from FDA if the EUA fact sheet would be updated, and likewise from CDC if the information sheets that the CDC has for parents and adults would have that information as well. Thank you.
Dr. Fink, would you like to comment on that? If you're still on the line.
Yes, and thank you very much, Ms. McNally, for that question. FDA has been working very closely with our partners at CDC in assessing the evolving data on this issue and interpreting the results. I think we're very much aligned with the information that's been presented today and do agree that based on the available data, a warning statement in the fact sheets for both healthcare providers and vaccine recipients and caregivers would be warranted in this situation. We thought it would be important to hear the discussion from the ACIP meeting today before finalizing language on these anticipated warnings. I can tell you that the warning statements would likely include information stating that these events have occurred in some vaccine recipients, particularly following dose 2 of mRNA vaccines, that onset of symptoms typically have been several days to a week following vaccination, that based on limited follow-up, most cases appear to have been associated with resolution of symptoms, but that limited information is available about potential long-term sequelae, that symptoms suggestive of myocarditis or pericarditis should result in vaccine recipients seeking medical attention. And finally, we would anticipate that the warning statements would refer to CDC clinical guidance on use of mRNA COVID vaccines in individuals with a history of myocarditis or pericarditis, as Dr. Oliver just presented. We anticipate that following today's ACIP meeting, we would move rapidly to update the fact sheets with this information. Thank you.
Thank you very much, Dr. Fink. Dr. Cohen.
I'll just follow Dr. Fink's comments that CDC will coordinate closely with FDA after the language has been finalized and update all of our fact sheets and parent information sheets to reflect the same language, although potentially at the appropriate reading level for the documents.
Thank you. Dr. Fry.
Thank you, and thanks for great presentations again. Slide 39 caught my attention, and that is the vaccine consideration in people with a history of myocarditis or pericarditis. And I was just a little bit concerned with the language in the fourth line, myocarditis after the first dose prior to second. I'm not sure how easily interpretable or user-friendly that language might be, because as we know, myopericarditis, you can have myocarditis and pericarditis at the same time, and it's not always easy to differentiate frequently, and I would think in the clinic it might be difficult. And so I was just thinking about another way to word the language in that fourth line. I'm just bringing it to your attention because I think there will be some confusion related to it. I don't know if others feel the same way.
Thank you very much, Dr.
Thanks.
Fry.
This is Dr. Oliver. We'll take that under consideration. I also want to highlight that there will be more language than just this. This was just an attempt to provide kind of an overall summary, but there's more context that will be provided when it's officially published. But we'll review that carefully. Thanks.
Thank you.
Thank you for that clarification. Dr. Alt.
I wanted to say thank you to Dr. Oliver and that small dedicated group that she mentioned. I thought this presentation was quite clear, and I would agree with the findings. The thing that I would like to see, speaking as an ACIP member, I think what all of us would like to see is long-term follow-up of these patients, and I'm wondering if there's not a standardized way to follow those patients up. I'll let the pediatricians and the cardiologists comment on that, but I'm wondering if, since it's a relatively small number, if we wouldn't gain more information if we suggested some way to standardize follow-up for them.
Thank you.
Thank you so much. This is Dr. Oliver. I expect discussions to be ongoing around that, so we'll Noted. Thank you.
Dr. Long.
Yes, it's a terrific presentation, and following what Dr. Fink said, you may be surprised to know all my questions and concerns about what we do here are finished. It was a warning that I wanted to be sure that we had, mainly because we do not know the long-term effect of this, and it may be nothing, but it may not be nothing. And I also am impressed with the Dr. Oliver and the work group's additional benefits for the males 12 to 17. I would have thought that the hospitalizations and the myocarditis cases would have been almost equivalent, but I believe you do the best work with the data, so I'm okay with all of these things, considering that there will be a warning. There's one question I do have, though, and a comment, and that is about consideration for people with a history of myocarditis and pericarditis. I wonder if you could give us just a little bit of insight on how you drew these conclusions. Are there any data?
This is Dr. Oliver. I will let you know we worked in close collaboration with Dr. Oster, who presented earlier, as well as the CISA team of cardiologists. Unfortunately, I don't know. Dr. Oster, are you still on?
I'm here, yes.
Okay, perfect. Do you want to take that?
Yeah, so we did discuss this at length, and first I would say any decisions, patients are advised to speak with their healthcare providers if they have questions. This is just guidance. So with regards, two kind of things came into play. So one, the risk of what would happen, and as Dr. Oliver mentioned, the risk of pericarditis once you have resolution of the symptoms is relatively low, especially compared to the risk of myocarditis that could be ongoing. Secondly, though, we talked quite a bit about potential mechanisms and what we know of who's had effects thus far. And while we don't know exact mechanisms, we know the patterns of classic myocarditis and even prior vaccine, induced myocarditis with smallpox. The patterns are very different from what we are seeing with the post-COVID myocarditis. So we thought we didn't have enough information there to recommend against vaccination in those instances, or even deferral, given that this seems to be a different, type of picture. But any discussion and thoughts are certainly welcome.
So it is interesting. I'm an associate editor of the Journal of Pediatrics, and we have received a case that did get through to publication, a single case report, and it is now up on the journal's website. If anybody wanted to look at it, the first author's last name is Minocha. This is from Manhattan, a case that I accepted because it was so beautifully proven. This was a 17-year-old boy who had traditional myocarditis in January with lots of investigation, including SARS, PCR, and antibody, both of which were negative in January, who recovered normal findings in cardiac follow-up within a month of discharge, who then in April received Pfizer dose number 1 and without difficulty. 2 days after Pfizer dose number 2, which was the appropriate interval, he had the sudden onset of severe chest pain going to his left shoulder, and again was investigated very thoroughly, had all of the findings that would confirm myocarditis, including the cardiac MRI, and had no PCR positivity, had IgM antibody at the time he presented with the myocarditis. So, because Dr. O'Leary has educated Dr. Long in public about what's rare and very rare, we would consider he would consider myocarditis viral traditional as rare or very rare. We want everybody to know that in this age group, recurrent myocarditis would be probably 3 varies and rare. So I would be a little cautious about this, not because of a single case, but of a very well-documented single case. And I don't know what the answer would be about what I would do for the patient in front of me. It ought to be a very unusual circumstance, but I don't think I would be so certain as those words sound about what I would do for administering vaccine. Sorry for the long diatribe, Dr. Romero. I'm finished.
Thank you for that comment and the case. All right, we'll move on to Dr. Sanchez.
Thank you, and great presentations, and I appreciate them a lot because it is a big issue that is facing us as we make recommendations for these age groups. I agree with the recommendation that the benefits certainly at this time outweigh the potential risks. I do think that we need to be very upfront in terms of mentioning this as a potential risk of COVID messenger RNA vaccination. And hopefully the parents and patients are aware of this before vaccination, not in the sheets that are given to them after they've received vaccine. So I think we need to really be upfront about this. And then my question really, and my issue is if you go to the previous slide with the 4 recommendations, or, well, the one that you have, the 4, yes. So, pericarditis after first dose and this is the second one, pericarditis after first dose of the messenger RNA COVID vaccine, but prior to the second dose. Personally, I would be very hesitant to provide a second dose of the messenger RNA vaccine. I understand that pericarditis is not the same overall risk as myocarditis, but I don't know if the second time around it's going to result in worsening. Whatever triggered it the first time, I think we just don't have enough information currently for me to be saying point blank that I'm going to proceed with a second dose of that vaccine at this time. And so I'm a little bit hesitant to make that recommendation in my practice. And definitely, obviously, we need long-term follow-up, and I hope that we can come up with and I think Dr. Alton mentioned that, I hope we can come up with a recommendation of what tests should be done on follow-up of all these children who've had pericarditis and myocarditis so we can assess the long-term outcomes. Thank you.
Thank you. Dr. Paling.
Oh, thank you very much. I want to thank the work group as well as our presenters on a fantastic presentation that really outlines and clearly outlines both the benefits and the risks. And I wanted to thank the FDA and the CDC for clarifying that there will be warnings that are available for both healthcare providers as well as patients so that all are informed. That is really important. I agree with others that from the information presented, the benefits clearly outweigh the risk. Now, in looking at the second question, additional information, the presentations all along throughout the COVID-19 have highlighted that there's disparities with race, ethnicity in outcomes for COVID disease And so as I'm thinking about myocarditis and any other effects, I would really like to pay attention to the race, ethnicity in the myocarditis or any other signals that we may detect. Thank you.
Thank you. Let me see. It's Dr. Daly. Forgive me.
Yeah, I have a question, a point of clarification that's directed to either Dr. Wallace or Dr. Oliver. So I was really struck on slide 14 that there have been roughly 2,700 deaths in this 12 to 29 year age group and 316 deaths since April 1st. And back of the envelope calculation, that would be 3 to 4 deaths per day. And so I was a little bit surprised that, and I think the vast majority of these deaths are vaccine preventable deaths, given what we know about the effectiveness of these vaccines. And so I was a little bit surprised at the relatively low number of deaths averted in the modeling. And is that a consequence of the fact that case rates are really low in the U.S. right now? And that sort of doesn't factor in what you've already anticipated, which is with moderate vaccination coverage and circulation of transmissible variants, we might expect rising case counts in the fall, for example. So if you could clarify sort of the modeling involved in deaths averted, that would be great. Thank you.
Yes, of course. This is Dr. Wallace. So there are three things that are really driving it. The first is what you mentioned, that right now, we base this on hospitalization rates that are occurring right now, which are, some of the lowest that we've seen thus far. I think the second thing is, the proportion of among those hospitalized in this age group that result in deaths is also quite low. We know that children have the lowest mortality rates, COVID-19 associated mortality rates overall. So that's showing up as well. The third thing is that this has been calculated over a 120-day time horizon. So that really limits the amount of time that this risk can accumulate deaths. So it's really the culmination of those three things. And I guess also the other thing is that the model does remove those that are already vaccinated. So we're assuming that those already vaccinated, are not in this risk pool.
Thank you.
Thank you.
Dr. Oster, I see your hand up. Did you want to make a comment about something previous?
Yes, thank you. I just wanted to follow up on Dr. Long's comment. I was able to quickly review that paper and just had two comments on that with regards to the guidance that was given. First, a timeline of about 3 months from myocarditis to vaccine. We put in there, and this gets to the long-term follow-up, that we really want to see resolution of the myocarditis and full heart recovery. And as Dr. Oliver mentioned, there is other verbiage that will be in the content to talk about exactly what that means. And a lot of that is taken from some of the guidance of American Heart Association, American College of Cardiology, which do recommend about a 3 to 6 month window of allowing the heart to recover. And then second, it is important to follow up on especially abnormal findings. And I was struck in that paper that the distribution of inflammation in the follow-up myocarditis was identical to the MRI in the acute phase of the earlier myocarditis. And it does not appear that there was an intervening MRI to show that had resolved. So it is important, and I think your thoughts are very well taken, and we want to emphasize that people have ongoing concerns, ongoing considerations are still followed. It was really kind of meant more for those who have a remote history of myocarditis that have essentially been off cardiac medications and discharged from cardiology care, who we felt that this was safe for. But thank you.
Thank you for those comments and for reviewing that report on a rapid basis. Dr. Lee.
Thank you. I wanted to respond to the second question, which is what additional information could inform these discussions. In part, I think there's a couple things. I'm very comfortable with the benefit risk balance as we know it today, and actually want to just highlight and recognize Dr. Wallace and Oliver for their work and making sure that we are assessing dynamically the benefit-risk balance as it is today, which is, the best possible assessment we can give and the fairest assessment. The question I have really is looking ahead to the future. So, as vaccine trials continue in younger age groups, I'm feeling a strong need to have deeper information on understanding the burden of disease in pediatrics. Understandably, we have focused much of our efforts on older adults where they have, really carried the burden of morbidity and mortality. But as we move closer towards decision-making on children and understanding the benefit-risk balance, I just really want to advocate for, having more information, understanding these cases, understanding, symptomatic versus asymptomatic disease and the consequences and outcomes associated with both symptomatic and asymptomatic disease. I think that could be incredibly helpful to us as we're looking ahead and understanding at a more granular level the benefit-risk balance. So any efforts in that area, I think, would be much appreciated because it's going to be continue to be a challenging set of decisions we have coming up. The second point I wanted to make is just that, and again, so appreciate the efforts that have gone into trying to estimate the benefit-risk balance, which is really hard to do on a continuous basis for every single discussion we have. But for clinicians and for the public to think about the fact that these are sort of pooled estimates across the nation, but there is so much regional variability with regard to disease risk and rates of vaccination in communities, that if you are in a community with very low rates of vaccination, your risks are just intuitively higher, and that the benefit-risk balance may look, may tip very favorably over towards the benefits are going to be far, far, far greater than any risks. And so thinking about it that way becomes really important as individuals are making decisions about vaccination. And again, advocate and support that every, we are talking about at the population level, but really it's at the individual clinician, patient level where a lot of these decisions are happening. And as much as we can do to support those decisions with transparent and available information that's up to date, I think, we will continue to do that, but hope that people will consider that the risk is not constant across the U.S. Thank you.
Thank you. I'm going to open this up to the liaisons to ask questions or make comments quickly. Dr. Howell.
Hi, Molly Howell, representing AIM. I guess one question I had, and I don't know if this was discussed in the work group, is the benefit to adolescents and young adults who previously had COVID, and would that change the benefit-harm analysis for receiving the COVID vaccine with the risk of myocarditis?
This is Dr. Oliver. The work group discussed kind of a variety of thoughts and permutations on the benefit-risk balance. Ultimately, I think we need or would love to have additional data around risks and benefits as it relates to people who have previously had COVID. It does not, to kind of our current knowledge, as Dr. Shimabukuro said, that prior COVID does not seem to, increase necessarily the risk of developing myocarditis. But that's something that we'll definitely keep an eye out for as we get additional data, and we'll continue to discuss.
Thank you. A hand is up by Shelley L. I don't have your last name on here. Who wishes to ask a question?
Hi there. Sorry about that. It's Shelley Deeks. I'm the chair of Canada's National Advisory Committee on Immunization.
Of course, go forward, please.
My question is, in terms of additional information, whether, given what appears to be a differential risk for Moderna versus Pfizer, and upcoming approval for younger age groups well, we're having that in Canada for Moderna. Whether the working group is going to continue to look at whether there is a differential risk benefit and potentially look at separating the two mRNA products rather than looking at them combined. Thank you.
Thank you. Any other questions from our liaisons? Dr. Bernstein, I will take your question as the last question from the voting members. Go ahead.
Thank you. This is for Dr. Oster. I just wanted to to clarify, when one thinks about recovery criteria from myocarditis, whether it's from the vaccine or associated with the vaccine or otherwise, are the criteria standard then? And so that for any of these patients, it will be clear throughout the country what we're looking for?
There's on mute. So for follow-up of traditional myocarditis, what the American College of Cardiology and American Heart Association recommend is improvement in symptoms, lack of any abnormal rhythms on whether that be ambulatory monitoring or stress testing, and return of normal function. The role of MRI is less clear in the guidelines written 6 years ago, although in practice many places do use that, especially if someone had abnormal MRI findings at their time of presentation. And many of these post-vaccine myocarditis kids do have that. There is certainly some variability in practice in terms of timing and how much testing people will do. But that's what we have so far, that is out there in terms of general long-term guidelines.
Thank you. Yeah, anything that we could do to standardize that, especially when there's going to be discussion between patients, providers, and the clinical team, including the cardiologist, would be valuable.
Thank you. So let me add my.
I do need to step away, but Sarah can email them to me. I'm actually in clinic today. Thank you.
Thank you, Dr. Oster. Let me add my comments to those that have been given before, and then we'll close this and get ready for the public comment. So to address the first question, I clearly think that the presentation that you've given today shows a benefit-risk balance in favor of benefit, and I feel very comfortable with that decision. And the way it's presented, I think, will serve me as a clinician in explaining to parents that have some hesitancy regarding this. Second of all, with regard to the clinical guidance, I think it's appropriate, and I know that there will be more detail in the actual MMWR or CDC presentation of this data. Lastly, what is needed? So from my point of view, this is now, and what happens in the future is unknown, especially with this Delta variant that is causing more and more disease. And I can tell you that in my state, we've had a takeoff in the number of cases in the last 2 weeks. And so I would want to know if the disease presentation in children is any different for that variant, that is with regard to severity, hospitalizations, MSIC, and with regard to outcome, morbidity and mortality. And that will further inform me regarding whether to continue to use these vaccines. To follow lastly on a comment by Dr. Lee, that I think based on the comment about politics, that all politics is local, I guess all advice regarding the use of a vaccine is local. But it's very important, at least from my point of view, I want to add the issue of race and ethnicity. And the recommendations that we make need to take that into account. Knowing that that 62% of Latinos and cases of MIS-C are reported in children of Latino or Black heritage. In my state, more than looking at the numbers right now, but 35% of all of our cases in children involve Black and Latino children. And so those inform me and will, I think, inform others about the need for recommendation of this vaccine and the vaccine for use in kids. So I'll stop here and I'll give us, Dr. Cohn, do you want to give a couple of minutes break or fine? We'll come back at 35 after the hour and begin the public session. Thank you very much.